Hey, I think we're starting to get a quorum, so we'll go ahead and start and thank everybody for joining today. We're excited to have Tim Nellen, and Tim can expound upon his credentials. But anyhow, did his fellowship here, and at CHOP is a neonatologist and is entering his fourth year. Did I get that right? Yes, I did.
Yep.
And so he's actually has been really interested in looking at the effects of a number of different environmental exposures, and in particular air pollution, and its effects on development, fetal and newborn development. So today we're really excited to hear him speak about his latest research. And with that, Tim, you're on.
Awesome. Thank you so much for that introduction. Um, all right, so this should be showing now. But thank you so much for that introduction. I said, yeah, my name is Tim, and I'm a neonatologist here at CHOP. And as Becky mentioned, I'm really interested in the environment and how it pertains to long-term outcomes of infants who are born preterm. I don't have anything to disclose. The only real thing is that a lot of ideas at the end of the day in my world get formed out of looking out of the window of my office, and this is the view from the Roberts Center. And I really like this because you can see West Philadelphia and the University of Pennsylvania there in the background, where many of the parents and infants that we take care of reside. You can look out this way and see West Philly. I can walk over when I'm eating lunch with Nick Novick, and you can see Center City. And it's really the juxtaposition of these two pictures here just reminds me that some of the exposures that infants face are built, and they can't escape. And so that is life in their home environment. But some of these exposures are transient and they don't follow lines, like air pollution doesn't know boundaries. All likely contribute to health. Outside of this, I've been really interested in investigating how the environment contributes to preterm infant health. So the conceptual model I would like to invite for today is something that again has been guiding me for the past 4 years or so. And it's that there are numerous neighborhood environmental exposures. These exposures contribute to increased risk of preterm birth and adverse birth outcomes. You then have preterm infants or infants in the NICU. And those same infants who are born preterm or needed to go to the NICU are facing the same environmental exposures that contributed to their risk of preterm birth and visiting to the NICU. And so it's all a vicious cycle almost. And I think it's really important to understand these neighborhood environmental exposures. And so ultimately, what I would like you to take away from this talk is that the environment is complex. The same environmental exposures that led to an increased risk of preterm birth are those same exposures that preterm infants face after they go home from the NICU. And that healthcare utilization after NICU discharge is associated with both the built and the breathed environment, and that there are numerous opportunities for place-based interventions. So on this first step, we'll just I'll expound a little bit on the neighborhood environmental exposures that we have been studying. So the first of which is air pollution exposure. And likely don't need to tell any of you here that air pollution is a mixture. It is heterogeneous. It's comprised of a number of different particles of a number of different sizes. For the majority of this talk, we'll actually focus on PM 2.5 or fine particulate matter. That is particulate matter that's less than 2.5 microns in diameter. It is really intriguing to me from a health point of view, as it is able to cross the pulmonary epithelial barrier. And so in doing so, it can have direct effects on the lung. It can also have systemic inflammatory effects on the rest of the body, and it is associated with a number of adverse health outcomes. This graph on the right just demonstrates that PM 2.5 overall, since between 2000 and 2015, was overall decreasing. But I do think it's important to note that like many of these environmental exposures, they're largely not by chance, and that there are actually racial disparities that exist in air pollution exposure in the United States. And as I just showed, is that PM 2.5 was decreasing from 2000 to 2015. We've actually seen a stagnation and actually slight increase depending on what part of the country you're living in. And this initial decrease was due to policy change, like the Clean Air Act. And we can see the evidence of that. And then you see relaxing of certain restrictions, and you can see a stagnation. What you can also see when you divide it by different parts of the country is that climate change, wildfires, and it's really wildfire smoke in the Northwest, West, and Southwest actually contributed to a sharp uptick in PM 2.5 exposure in the United States, with the rest of the country having either a blunting of the descent in PM 2.5 exposure or a stabilization as well. It's also really important. It's getting hotter. And so kind of in 2023, it's kind of the hottest year on record. Kind of the bottom left there was a kind of screenshot I took from the New York Times just the other day that global temperature shattered records in January. And so things are getting hotter, kind of depending, and that is kind of that is true, regardless of what people say. And why is this important? And if there are numerous serious health impacts from heat, and kind of they're thought to actually result from high nighttime temperatures. And so it's kind of those temperatures at night that have been shown to be more strongly associated with kind of mortality than daily maximum temperature. However, kind of there are numerous studies to suggest that numerous types of heat exposure are bad and are associated with a number of adverse health outcomes. In the United States, kind of I showed kind of the whole world, and kind of it's getting hotter here. Kind of heat waves are increasing in frequency and duration. The season in which heat waves are happening is getting longer. Kind of the heat waves themselves are getting hotter, and you can see that both kind of the daily highs and the daily lows are kind of both increasing in the United States and have really started to kind of uptrend since about 1980. But I do think it's important to call out that the neighborhood environment is a really tangled web. And so kind of just kind of with air pollution and heat, and then we can get into things like green space and clean water, kind of those are almost inextricably linked with things like community material neighborhood deprivation. So things like kind of household income, education, housing, access to care, kind of both of those things go hand in hand, and it's kind of really hard to disentangle kind of those two exposures. So just calling out here that kind of the neighborhood environment is a really tangled web. And it's important to note that the built environment does contribute to health. Demonstratively, the United States has maternal mortality rates that are actually higher than Turkey, Lithuania, Latvia, Hungary, and Portugal. And rates have also been increasing. And differences in kind of neighborhood vulnerability likely account for at least part of these trends. This neighborhood environment is not the result of chance. So note that kind of birthing parents that are kind of Black and American Indian or Alaskan are 2 to 4 times more likely to die from a pregnancy-related cause in the United States compared to white birthing parents. And then while you note that kind of maternal neighborhood vulnerability is significantly higher among kind of Black and American Indian and Alaska Native birthing parents compared to white birthing parents. And these disparities exist right outside of our door. So this is Philadelphia County right here. And just note that Philadelphia ranks in the 87th and 94th percentile nationwide when it comes to socioeconomic vulnerability and physical environmental exposures. And it's overall kind of in the 61st percentile when we think about kind of vulnerability as quantified by this maternal vulnerability index. And compare this to Montgomery County, which ranks in the 0.9th percentile. So there are kind of really clear disparities kind of right outside of our door. And just include this. This actually went on the EPS website last week and was kind of just searching kind of environmental justice as I trying to download some kind of air pollution data. And this is what I got. Fortunately, I actually just went back today to double check, and it's back up at the moment. But I think that it's incredibly important just to kind of call this out, that kind of regardless of what kind of the powers at be say, that kind of the environment is important and does exist. And kind of all that's to say is that I'm really grateful for the Children's Center and kind of its commitment to continuing to investigate the role of the environment and kind of think about ways to mitigate the impact of the environment. So for the first part, kind of we'll get into the increased risk of preterm birth and adverse birth outcomes. When we think about preterm birth as an outcome, it is often studied as kind of preterm birth, yes or no. But I just want to make the point that kind of preterm birth itself is not a monolith. And so it is birth before 37 weeks gestation, but it can actually be spontaneous, or it can be medically indicated. So to say if a mom comes in with really high blood pressure or bleeding or some other kind of medical condition, which kind of it is kind of imperative to deliver the baby, that is likely different than kind of a preterm birth where a mom goes into spontaneous labor early. It also varies by severity. And so kind of an infant born at 22 weeks is different than an infant born at 36 weeks. We also don't know if the causes of preterm birth at 22 weeks are different than 36 weeks. But my hypothesis would be that yes, they are. But just kind of show this to show that preterm birth is not a monolith, even though it's often studied as a monolithic outcome. And this is again just driving home the point that there are significant racial disparities exist in preterm birth rates, and as we investigate these disparities, kind of thinking about how the environment might kind of be contributing to some of these. And so the first quick point I will make is that kind of there's a litany of literature out there to kind of demonstrate that there is an association of kind of air pollution exposure with adverse birth outcomes, notably preterm birth, low birth weight, and stillbirth in the systematic review that was published a couple years ago in JAMA Network Open. The same authors also found that heat exposure was associated with these same adverse birth outcomes. This was actually a study published by Betsy Salazar, one of our neonatology colleagues, and she demonstrated that kind of increased neighborhood vulnerability was also associated with an increased risk of preterm birth. And so, as I mentioned, that kind of these are all studies, and all the studies included in that kind of systematic review, and have looked at preterm birth as kind of a monolithic outcome. But something that I've become really interested in is spontaneous preterm birth, which the American College of Obstetrics and Gynecology defines as spontaneous preterm birth following preterm labor, preterm rupture of membranes, or cervical insufficiency. And we really actually don't know how timing of birth is controlled in humans. And there are numerous potential contributors to spontaneous preterm birth. And I'm really intrigued because there are social stresses, physical environmental exposures, there could be an infection and inflammatory component, or there could be a genetic component as well. So I think this makes it a very kind of ripe outcome to study when it comes to the environment. And also just want to call out that not all air pollution exposures are alike. There are kind of astronomical variation in PM2.5 concentrations globally. There's also incredible variation in the United States. There's also differences in exposure timing. And so I think it's really important to look if kind of prior studies looked at cumulative exposure over pregnancy, were they trimester-specific exposures, were they exposures immediately prior to delivery? And all this to say is that I believe there's still a significant amount of work that's required to understand how environmental exposures are associated with specific preterm birth risk and phenotype. So to ask this first question, we actually performed a study to investigate associations of short-term increases in ambient PM2.5 with spontaneous preterm birth using a case crossover design at 2 Penn birthing hospitals in Philadelphia. This kind of won't be a deep methods talk, but the overview of kind of one of the benefits of the time-stratified case crossover design is it allows us to ask a question that has to do with the temporal association of an exposure and an acute event. And in this case, that was spontaneous preterm birth. It's used really widely in the epidemiology literature. And one of its strengths is that it avoids confounding by time invariant characteristics, long-term trends, seasonality, and day-of-week effects. So we think about how tangled the neighborhood environment is. This is actually a really nice way to be able to kind of just highlight and kind of suss out the impact or the association of PM2.5 with the outcome. So this, we generated the daily mean kind of air pollution exposures over the course of pregnancy for this entire cohort. It was inclusive of kind of over 6,500 singleton spontaneous preterm births, and there were over 100,000 kind of term births to compare to. We divided the PM2.5 exposure into quartiles, which you can see on the left side of the table. I just want to make the point that we found that there was higher proportion of spontaneous preterm births in the highest quartile of pregnancy daily mean PM2.5 compared to singleton term births. Here are the results of air pollution exposures just in the week prior to delivery with that kind of time-stratified case crossover model with spontaneous preterm birth. We actually did not detect any significant association of short-term changes in air pollution with spontaneous preterm birth and models adjusting for temperature. But I will note that while no significant association was detected, that all point estimates with exposure windows of 1 day or longer, so that is to say the air pollution 1 day prior to delivery to 6 days prior to delivery, were positive. And so kind of the quick conclusion kind of for this is that kind of while we didn't detect an association of short-term increases in PM2.5 with spontaneous preterm birth, it should be really important to understand the context that there are relatively low concentrations of PM2.5 in Philadelphia, and therefore this may not generalize to other settings or years, particularly thinking about how PM2.5 has decreased over the past 20 years. And there also may be a significant difference in cumulative versus short-term PM2.5 exposures that may exist. And all this is to say that the environment is very complex, and it's important to kind of use kind of methodologies that reduce confounding kind of by other environmental exposures. So for this next kind of portion of data that I will kind of share, kind of it delves more into kind of adverse birth outcomes and kind of infants that require NICU admission. And again, I'd like to kind of thank the Children's Center for kind of funding this work as well. And I think one of the really fun parts about being a neonatologist is that we get to think about both kind of maternal and infant exposures and how kind of maternal exposures impact child health. So I'm going to share our initial findings of heat exposure with an acute birth outcome related to fetal distress. For context, for those of you who aren't clinicians here, kind of meconium refers to the first stool that's passed by a newborn baby. And it's not uncommon to be called to a delivery in the hospital as a neonatologist because there's meconium-stained amniotic fluid at time of kind of rupture, and this is often caused by fetal stress. And we really care about this because if a baby breathes in some of this meconium-stained fluid, it can get in the lungs and cause a whole host of complications. And the idea for the study actually came after kind of a night on call and a conversation with one of my colleagues, Nick Novick, who noticed that during a heat wave last summer, that it felt like every single delivery that he was being called to was because of meconium. And so we thought, kind of, what might be the association of heat exposure prior to birth with meconium, and then meconium aspiration, and kind of the thought being that kind of there is some potentially increased fetal stress. We again use that time stratified case crossover design. And again, kind of one of the highlights of this was actually kind of example temperature distribution for our study in kind of 4 days in July in 2015 in Michigan. And you can see the vast array of temperatures here, and how kind of temperature is not a static thing, and it kind of varies significantly by day. And so kind of it makes this sort of approach kind of very appealing. This is kind of the results from kind of our primary analysis, looking at just meconium stained amniotic fluid at birth. We actually were able to detect this outcome in over 27,000 infants over a cohort of 460,000 eligible term births in the state of Michigan. And just to orient, kind of the column on the left is just the temperature in the week prior to birth. And the column on the right is the kind of the risk of the adjusted odds of having meconium stained amniotic fluid at birth. And what we found was there's significant association for temperature in that week prior to delivery with meconium at all kind of time points of 2 days and longer in that week prior to delivery. As I said, kind of there are a whole host of complications kind of with having meconium stained amniotic fluid, and kind of one of the biggest ones that we are concerned about as neonatologists is meconium aspiration syndrome, which often requires infants to need a breathing tube and have to kind of have care in the NICU. And so we looked at this outcome, which we had charted for 269 infants, and so a relatively small number. So this table displays the results of that, and with the temperature in the week prior to the birth on the left side, and the adjusted odds ratio on the right column. And we actually did not detect any significant associations of temperature with meconium aspiration for any lag period, but note the magnitude of the point estimate is higher. And so to put this into context, this was a relatively large, this is actually a huge sample size over a 17-year period. And we used a modeling approach to adjust confounding. And I'm sorry, this should say that we kind of stratified by delivery year and not preterm birth severity. And we're able to kind of look at that as well. This was just one geographic region, and kind of we do assume an equal effect of temperature across those kind of exposure days prior to delivery. And to kind of start to address that limitation, kind of we've started to look at an exploratory analysis about, is the effect of temperature linear? And these are 3D plots of temperature, exposure, kind of lag or exposure time to that temperature and effect size. And I'm not going to go through the specific results of this, but I just want you to, this is very preliminary at this point, but I just want you to note that the relationship of this likely does not appear to be linear. And so you can see the waviness of the shape, and that suggests that there's a complex relationship between the degree of temperature exposure and the amount of time exposed to that temperature as well. So and there are some very complex interactions of kind of temperature as they pertain to kind of birth outcomes. So kind of broadly, we found that an increase in temperature was associated with meconium at delivery. And then while we lack significance, likely due to a smaller sample size, point estimates were positive for meconium aspiration syndrome as well. And so future studies should focus on periods of extreme heat, using different definitions of exposure, kind of expanding outcomes to look at things like infant mortality and other perinatal health outcomes, and a really specific attention to the impact of heat and its relationship to those health outcomes. And so we've now talked about kind of the neighborhood environmental exposures, increased risk of preterm birth and adverse birth outcomes, potential kind of instances in which infants may require a NICU admission. And next, I'm going to talk really about the meat and potatoes of kind of my work so far at CHOP. That really has to kind of to do with infant healthcare utilization after NICU discharge. So as a neonatologist, I am really interested in a disease called bronchopulmonary dysplasia, which occurs in preterm infants who are born at less than 32 weeks. It's actually the most common morbidity of preterm birth, and these infants are at risk for a number of adverse health outcomes. But there's still kind of an understudied area in terms of I'm trying to understand the environmental impact on the health of these infants. And one of the strengths of CHOP is that it actually has kind of a world-renowned kind of newborn and infant chronic lung disease program that kind of takes care of infants who are born in West Philadelphia, but it could also take care of infants who are transferred in from 5 states away. And so it makes it a really fertile place to kind of gain clinical skills and take care of these patients, but also to be able to do some of this environmentally based research from having just a large sample size of a relatively rare disease. And while there is an abundance of research and work into kind of improving the care of these infants and preventing BPD, There's comparatively little in understanding kind of the life course of these infants, and a relative knowledge gap in terms of trying to understand kind of the impact of the environment, though it is growing. And so kind of would like to just kind of call out and kind of people who have kind of been very helpful in kind of growing this culture, particularly as it relates to kind of BPD at CHOP, with kind of Sharon McGrath Morrow, Jessica Rice, who I think I saw on the call as well, and Yeltha Kochtemans as well, who have done kind of awesome work in the Division of Pulmonary Medicine, and hope to collaborate with in the future. But kind of the growing need to kind of really understand the longer term health outcomes of preterm infants. And so kind of given kind of CHOP's place, we were actually able to develop a cohort of 378 infants with BPD who had a discharge address in the Metro Philadelphia region. And this allowed us to look at kind of post-NICU healthcare utilization and associations of the environment with that. So these are the characteristics of our cohorts. As I mentioned, there are 378 infants. And just want to note some baseline characteristics that infants with more severe illness at baseline were more likely to have an acute respiratory illness in the first year after NICU discharge. That kind of infants who are identified as non-Hispanic Black were actually more likely to suffer an acute respiratory illness as well. So for this first part, and again, just noting that the neighborhood environment is complex, and we'll look at social vulnerability as quantified by the CDC Social Vulnerability Index, kind of which used to exist. And I hope that kind of will continue to exist at some point in the future. But the Social Vulnerability Index is kind of made of kind of 15 different categories of variables that have to do with kind of socioeconomic status, household composition, minority status, housing type, and transportation. And that's right, let me go back here. And the map on the left shows kind of the social vulnerability in Philadelphia. You can note the darker shades of purple represent kind of more vulnerable areas compared to the lighter shades of purple. And note kind of the deep purple kind of right around CHOP, which is kind of there in this kind of red dot in the middle, and around kind of North Philadelphia, West Philadelphia, and then kind of Camden, New Jersey as well. So we found that infants with acute respiratory illness came from census tracts with higher social vulnerability index values. And when we did modeling, we actually found that there was a significant association of the social vulnerability index with acute respiratory illness, even after we adjusted for patient illness risk factors and demographic risk factors as well. And as I mentioned previously, that there are significant racial disparities that exist in acute respiratory illness, for medically attended acute respiratory illness, for ED visits, and for inpatient readmissions. And so kind of what we found is that there was significant mediation of that racial disparity by increased exposure to social vulnerability in the neighborhood. And kind of that was kind of 31% for ED visits. And so kind of that's just another way of looking at kind of racial disparities and noting how different neighborhood exposures contribute to those disparities. So the broad takeaway from this part is that census tract SVI was associated with acute respiratory illness, and that may be driven by factors associated with race and ethnicity, but it's important to note that kind of the built environment and kind of likely racism, not race, contributes to those disparities in outcomes. But what about the factors that make up the physical environment that we talked about? So for this next portion, we'll talk about certain environmental determinants of post-discharge acute respiratory illness. And we actually looked at the CDC's Environmental Justice Index, which also used to exist, which is actually composed of 3 modules, 10 domains, and then 36 indicator variables. The social vulnerability module is actually what we just looked at previously. And then it's also composed of the environmental burden module, which is of particular interest to us, and then the health vulnerability module as well. And we'll note that with this, something that I think is really compelling about the Environmental Justice Index is that it puts things into proportion. And so from a policy perspective, it can be kind of really helpful. And so kind of it ranks census tracts based on the kind of relative exposure to certain kind of environmental factors, air pollutants, compared to other census tracts in the country. And then ranks them on a percentile score from 0 to 1, with 1 being the highest and 0 being the lowest. So it's not an exact measurement of air pollution exposure, but it is relative to kind of other exposures in the country. This is the Environmental Justice Index in Philadelphia. And again, note kind of the deeper shades of purple represent kind of more vulnerable areas, and the lighter shades of purple represent less vulnerable areas. And you can again see those kind of deeper shades of purple right around West Philadelphia, North Philadelphia, Camden, New Jersey, and then off into kind of certain kind of suburbs as well. And what we found was that infants who were exposed to higher levels of environmental injustice had 39% higher odds of acute respiratory illness in models that were adjusted for kind of demographic and kind of clinical characteristics. When we dug deeper and looked at the air pollution domain, which includes PM 2.5, diesel particulate matter, ozone, and air toxic cancer risk composite score. We were able to kind of show kind of the air pollution domain in Philadelphia. And again, it's really interesting to note kind of the area of deep purple kind of right around Center City. And then you can see kind of I-95 going from kind of northeast to southwest there. And then 76 as well. And so kind of you see kind of significant areas of kind of higher air pollution exposure. When we look at the air pollution domain, that infants exposed to high levels of air pollution actually had 58% higher odds of acute respiratory illness in those similar models that were adjusted for clinical illness and demographic risk factors. And when we parse the air pollution domain into its different indicator variables, looking at ozone, PM 2.5, diesel PM, and air toxic cancer risk, and we see a different array of kind of the exposures that kind of kids and kind of families face in Philadelphia. And we also found that kind of exposure to PM 2.5 was associated with significantly higher odds of acute respiratory illness, as with diesel particulate matter and the air toxic cancer risk indicator score. And these were all in models adjusted for kind of patient illness and clinical risk factors. So environmental justice is important, and kind of these environmental exposures are associated with acute respiratory illness. There's significant association of census tract with kind of air pollution exposure with acute respiratory illness. And all these things are measured at the census tract level. So how can we investigate this at a more granular level? And so to do that, we looked at kind of PM 2.5 and really honed in on kind of one air pollutant at the census block group level, which is kind of akin to like Russian nesting dolls. And there's many census block groups that are nested within a census tract. So here is PM 2.5 in the Metro Philadelphia region. And we were actually able to collaborate with Alan Just, who is an environmental epidemiologist at Brown University, to use a machine learning model to generate kind of daily PM 2.5 exposure for our infants after they left the NICU. Note that the kind of PM 2.5 concentrations range from kind of just over 11 to right around 6 micrograms per cubic meter. And there was significant regional variation within the Philadelphia region. We actually found that there was higher PM 2.5 exposure among infants with grade 1 BPD who had acute respiratory illness, but otherwise there were no significant differences that existed. And then when we kind of fully modeled this, we actually did not detect a significant association of PM 2.5 with acute respiratory illness and models that were adjusted for clinical and demographic risk factors. When we stratified by kind of the grade of BPD or how sick the kids were at baseline, we actually found a significant association of PM 2.5 with medically attended acute respiratory illness among infants with grade 1 BPD, so kind of infants with more mild disease at baseline. And this was largely driven by an increased risk of ED visits. So to take this to a more kind of policy or intervention level for translation, for context, EPA recently decreased the threshold of PM 2.5 exposure to 9 from 12 micrograms per cubic meter. And so we wanted to model the impact of PM 2.5 reduction on acute respiratory illness among these infants. So we did that by measuring the average marginal effects of decreasing annual mean PM 2.5 by just 1 unit. And this is what the graph shows here with ED visits or readmission on the left and mean PM 2.5 exposure on the x-axis. And what we found was that there was kind of per 1 unit decrease in PM 2.5, there's nearly a 10% reduction in acute respiratory illness, either having an ED visit or inpatient readmission in that first year after NICU discharge. And this was most prominent for visits to the ED. So how does this translate to the real world? Say that there are 50,000 infants who are born at less than 32 weeks gestation in the US. About a third of them will be diagnosed with grade 1 BPD, and about a third of them will have an ED visit or inpatient readmission in the first year after NICU discharge. That amounts to about 400 fewer infants with grade 1 BPD per just 1 unit of decrease in PM 2.5. 400 fewer infants would require an ED visit or admission. So while that seems small, kind of when you scale that up to include kind of all of kind of the United States and the healthcare costs of these infants, there's a very sizable kind of impact there. And so in terms of the environment and respiratory outcomes, kind of both the built and the breathed neighborhood environment are associated with health outcomes among infants with BPD. We actually also showed that reducing PM 2.5 by just 1 unit was associated with a decrease in post-discharge respiratory illness, and that was especially true for ED visits. So kind of both to say that environmental health policies have real implications for infants, and the neighborhood environment is really complex. And so there are numerous factors that contribute to an infant's environmental exposome. And what if we look at longer term outcomes? And so kind of this study was kind of born out of just that. And so we wanted to look at kind of the community material neighborhood deprivation, so like the kind of the economic health of the neighborhood, if you will, and the risk of asthma among these same group of infants. And why we wanted to do this is because asthma is kind of actually the most common pediatric respiratory disease. We know that preterm birth and BPD are both risk factors for asthma. We also know that socioeconomic factors are associated with the diagnosis of asthma. But what we don't know is if socioeconomic factors are associated with asthma among this patient population. So this is the Community Material Deprivation Index in Philadelphia. And again, the darker shades of purple represent have more deprived areas, and you can see the same trend of kind of where these hotspots are. And specifically that there was an association of asthma diagnosis with neighborhood deprivation in these infants. And specifically, these infants live in census tracts with more poverty, lower household income, lower levels of educational attainment in the household, higher levels of being uninsured, and more households receiving assisted income. And kind of when we did kind of our full models, we found that the Community Material Deprivation Index and asthma by age 5 were significantly associated. And so infants exposed to higher levels of community material neighborhood deprivation had 29% higher odds of an asthma diagnosis by age 5. And when we restricted to just infants who didn't require any sort of supplemental respiratory support at time of NICU discharge or weren't on any sort of inhaled medications at time of NICU discharge, actually had 40% higher odds of asthma by age 5. So very similar results. And these were in models that were fully adjusted for different clinical risk factors for developing asthma, as well as at birth, as well as during the NICU and at time of discharge. So the conclusion from this part is that higher neighborhood deprivation is associated with asthma amongst these infants. And it really kind of place dictates exposure overall, and place and health are kind of inextricably linked. And kind of just include kind of these pictures to kind of show kind of where the home environment in Philadelphia. And so kind of you can take a nice walk on the Schuylkill and kind of be in Fittler Square there in a couple of minutes from Chop and Pen. You can also kind of be down by the oil refinery, which kind of had a large explosion a few years back and be exposed to higher levels of air pollution. But there are some exposures that are kind of relatively static and some exposures that kind of don't cross or that do cross boundaries, and kind of air pollution is one of those. And so I think it's an important thing to continue to study. And so we've now come full circle talking about those neighborhood environmental exposures, how they contributed to increased risk of adverse birth outcomes, how those same kind of infants who had those adverse birth outcomes stayed in the NICU, and then how infants' healthcare utilization after NICU discharge was influenced by those same neighborhood environmental exposures. So to close this off, I'm just going to discuss some potential interventions and next steps, and one project that we are currently completing it at the moment. And so when I think at least about kind of certain interventions, we can think about different place-based interventions. And so that is to say that kind of what's going to work in kind of Philadelphia is probably going to be different than what works in Denver, Colorado, or Seattle, Washington. And so I think it's important to take all of those things into account. But we can think about interventions also from kind of a very kind of place-based and individualized, and we can think about them all the way up to kind of policy level. And so for this next part, we'll just kind of focus on these kind of place-based and individualized interventions. And I think for those kind of place-based individualized interventions, it's really important to know, particularly for like preterm infants who have chronic lung disease, it's really important to try to understand kind of the parental perceptions of the environment and how kind of parents perceive the environment contributing to their health and their preterm infants' health. And kind of, as I said before, kind of that same environment is associated with preterm birth, is the same environment that kids go home to. So numerous interventions have been studied, but I do think that there's a little bit of a knowledge gap there in terms of understanding parental perceptions of the environment so that we can improve counseling, highlight areas for intervention, and kind of identify areas that might be amenable to higher level policy intervention as well. So I have to thank Iman Chen here for kind of helping us jumpstart this project. And kind of to kind of do this project, we actually bought a number of kind of air pollution monitors from Atmotube Pro. These are really small and portable, and that was kind of a big key for us. And they measure several different air pollutants and temperature as well, and they're actually really good for PM 2.5. And they're nice because they provide a real-time readout on the screen, and it's app-based as well, so it's on your iPhone or Android. So for this project, kind of we initially started, we were trying to enroll caregivers of preterm infants who were born at less than 32 weeks in the HUP NICU, which is a Penn birthing hospital. We had the parents kind of fill out a baseline environmental exposure questionnaire, and then we were planning on kind of distributing the air pollution monitor at time of enrollment. Upon trying to recruit kind of families, we actually received feedback from many families, and many families were turning down the study, saying that they actually would felt trapped by the idea of knowing what the air pollution level was and not being able to do anything about it. And actually, thanks to an incredibly industrious student that we had with us over the summer, Atmotube and Blue Air, which is another company, actually donated air purifiers to our study as well. So we were able to pivot and switch the study and able to kind of essentially distribute the air pollution monitor at time of enrollment before the kid goes home. And we were able to see at the level of PM 2.5 is higher than the WHO standard over the monitoring period, that we were actually able to send the family home with an air purifier as well. And kind of when we made that change, we actually were able to kind of enroll kind of 10 people very quickly after that. And we are in the process now. We've kind of fully enrolled kind of families, and we are in the process of now following up with the 1 month follow-up interview, which is aiming to kind of gauge caregiver perceptions of the environment, air quality, infant health, and quality of life. And so, as I mentioned, this is the current stage. We currently have 10 families enrolled. 5 of the 7 eligible families for the 1 month interview have been reached, and we've performed that 1 month interview. There are still 2 families admitted to the NICU, and 1 family was discharged just last week. The highlights from the semi-structured interviews thus far, and kind of lessons that I've learned, is that kind of there have actually been some families that have voiced hesitation with the air pollution monitor as an intervention. And as I mentioned kind of previously, before we had the air purifier, people were feeling helpless. But even after the air purifier, people still felt pretty helpless, knowing that there's dirty air. Like, what are they supposed to do? Are they supposed to kind of sit in the same room with the air purifier in it? And so there was some significant consternation among a couple of the study participants. There's also been a wide variation in air pollution monitor usage, which kind of really kind of took me by surprise, particularly for people who agreed to participate in the study. And what I mean by that is some people kind of turned on the monitor and were actually looking at the readout every day and in real time, and used it to kind of gauge their activities, do things like change out their air filters, decide when to take their kid outside. But there's some people who actually never turned the monitor on and just didn't really see the huge benefit of it. And so kind of one of the biggest roadblocks to uptake that we found anecdotally is just the perceived benefit on behalf of the parents. There's actually a range of parental perceptions of the environment as it pertains to infant health, with kind of some kind of making a link there, and others who don't see the environment as a kind of a huge kind of determinant of kind of their own health or their kids' health. But I will say is that the air purifier has been universally well received by everybody and has been a very welcomed intervention. And so this was just a small pilot study to generate essentially preliminary data for my ultimate K, which will be looking at associations of the environment with healthcare utilization and longer term outcomes of neonates, looking at neighborhood deprivation, air pollution, and heat. And we have shown that it's possible to distribute air pollution monitors and purifiers at time of NICU discharge. So the specific next steps are I'll be applying for a K-23 likely to dive further into those post-NICU exposures, looking at respiratory health outcomes at 2 years, looking at neurodevelopmental outcomes at 2 years, and then in a more formal way, assessing the feasibility and acceptability of an individualized non-healthcare intervention, which will be the bundle of the air pollution monitor and air purifier. And I hope to really take all of this work and turn it into future implementation work to be able to scale this up and determine the effectiveness of an air pollution monitor, air purifier, and reducing healthcare utilization, and working with different projects to determine the feasibility and or impact of how we implement these things. And all that's to say is because there's numerous times and numerous places where we can provide this intervention. And that's why I think that the NICU is another really great place that is ripe for studying and developing these interventions, because we have a captive audience for a number of months, up to a year. And then we have infants come up in follow-up clinic. There's leaving the hospital as well. And then we have our collaboration with pulmonary as well that I think we can hopefully tap into. And we can also see if the intervention is different depending on where the intervention is deployed. So to bring it all the way back home, what I ultimately want you to take away is that, again, the environment is very complex. Those same exposures that lead to an increased risk of adverse birth outcomes are the same exposures that contribute to adverse outcomes in infants once they leave the NICU. That healthcare utilization after NICU discharge is significantly associated with both the built and the breathed environment, and that there are numerous opportunities for place-based interventions. And so I'd just like to thank Heather, Alan, Scott, and Sarah, who have been my primary research mentors thus far for this work in fellowship. None of this work would have been possible without Josh, who is the statistician that I work most closely with, as well as kind of Nick, Kristen, and Daria. Sharon and Lisa have been incredibly generous with their T32 funding for both kind of protected time as well as funds to continue to do this work, as well as kind of pilot grants from the Children's Center and SEAT. So at this point, I'd just like to open it up to any questions.